So welcome to the third Clinical Strategy podcast. My name is Charlotte Routh and I'm one of our clinical strategy leads. Today we're here to talk about a public health approach and how that will help with our clinical strategy. So I'd like to welcome Jill Harland to us today. Jill is one of our public health consultants within the Trust and she's here to help me to discuss this today. So as part of our clinical strategy, we have a commitment to our patients about understanding their health needs and thinking about the wider aspects of health. So we want to think about populations, but also about personalised care. So Jill, let's talk about, we've heard about the phrase social determinants of health. So can you explain that to us?
Yeah, so when I think about social determinants, I think I use a word called building blocks. So if we think about the building blocks of health, they're things that really matter to our health outcomes. So where we're born, where we live, where we grow up, where we work, our education, whether we have enough money to be able to buy food, to be able to access the things that help us be healthy, are the building blocks of health. And while healthcare is really important to living a healthy, good, long life, these building blocks are equally, if not more important. And without those building blocks, it's harder to be healthy.
Yeah.
So it's really important when we're delivering healthcare that, as well as having really good quality, high quality healthcare that's personalised, we need to recognise that the circumstances in which people live really matter.
Yeah, and we've got a really big geographical area in Northumbria, haven't we? And with
Absolutely.
some very affluent areas, but also some areas where people are really struggling on a day-to-day basis.
Indeed,
so, yeah. So what we do to patients is not going to be the same to everyone.
Indeed, and it's about not one size doesn't fit all.
Yeah.
So if we're thinking about, for example, if a patient has asthma and we're sending them to, back home and in their home conditions might have problems with damp or, not well heated home, however good our medicine is and however good our clinical advice is, if they're living in those circumstances, it really does affect the ability of our healthcare to achieve its best.
Yeah.
So we need to understand that, and we need to work in partnership with the person to understand their circumstances, but also in partnership with the other organisations in their community.
Yeah.
So that might be about contacting the housing department, working with the local GP, thinking about the other organisations in that community that can support the person to address some of those barriers to them being healthy. It's really, really important.
Yeah, absolutely. And people talk about health inequalities. What does that mean?
So in public health, we use that word an awful lot because it's really, really important. And health inequalities are unfair differences in health outcomes. And we see health inequalities because of those building blocks and the differences in those building blocks. So people might have barriers to being able to access healthcare. They may have difficulties in maintaining good health. And we see that those differences, often people living in more areas where there's more deprivation can have poorer health outcomes than people living in areas where there are more assets and they have more things to keep them healthy. And often it's not the person's fault. So if we ignore those health inequalities and pretend that everybody's the same, we can actually make those health inequalities worse.
Yeah. So what are we doing as a trust to sort of start thinking about health inequalities?
So in our clinical strategy, one of the key areas that we've incorporated is looking at information and data. And some of that data is about numbers and some of the data is about qualitative information about kind of people's lived experience. So we're not just looking at numbers, we're looking at how different groups or different parts of the population might have different health experiences and different health outcomes. So we're trying to embed a health inequality view into our data. So we could look at, for example, people coming to hospital appointments.
Okay, yeah.
And if we were thinking of that from a health inequality perspective, we would look at, well, actually, are there differences for different groups? So do people who are living in more deprived areas come to the appointments in the same way as people who live in wealthier areas?
Yeah.
Or if somebody has a serious mental illness, are their health outcomes the same as somebody without a serious mental illness? So we're asking questions of the data that helps us see if there are differences for different groups and different people. And it's really important that we do that, because if we don't look for those differences, then we're not then asking the right questions to be able to change our way of working or adapt to the needs of the person.
Have you got an example for us of how you've worked with a clinical team to apply that?
Yes, so we've been doing some work with colleagues who work in colposcopy to look at their attendance at hospital appointments. And what we saw was that groups that were living in more difficult circumstances were more likely not to be able to attend an appointment.
Okay.
And when we saw that in the data, we then realised that we needed to speak to people.
Yeah, well, that's important, isn't it? Yeah.
Absolutely. So we spoke to the staff to get their perception of why that might be the case, but we also spoke to the people who we were inviting to come to appointments, and we also spoke to services that work with those groups. And that was really helpful, because what it helped us understand is that there can be barriers to prevent people coming to what we think is an important appointment.
Yeah, sure. Yeah.
So things like not being able to afford the travel costs to get to the appointment, not really understanding why the appointment was important. So we use health literacy. So that's about people's ability to read information and understand that information. So not everybody can read and understand information in the same way.
Sure. Yeah.
So our leaflets might not have been designed for the group that we were trying to reach.
Okay.
So we were able to understand that we needed to make some improvement in the way we communicated to patients about why it was important. Yeah. And then fear. So some patients might be worried about coming and not appreciate the support that we would be able to give to support them to come to their appointment, and busy lives, forgetting. You know, people have lots of things going on in their lives. They might be a parent with young children, or they might have work that
they can't miss.
Or they're not allowed to come to an appointment. So all of those things. So by being able to talk to people and understand some of those barriers, we put in place improvements, working with the team to look at what we could do differently. So we've improved information on our Trust website and the information we give patients about how to come and travel in to the appointment. Patients can get help with costs for travel, but sometimes that's not readily known about. So we've improved the way we share that information with patients. We also have improved the information about what to expect when you come to the appointment. So, and that this is an ongoing thing. So we're constantly listening and improving around that.
And what do patients think? Has it made a difference to attendance rates?
It absolutely has. So we were able to reduce the numbers of people not attending their appointment in the time period where we have done this piece of work. So we've been able to see measurable improvements. So it shows that those approaches do help, and now we're trying to roll out those approaches in other areas. So we're now working with colleagues in other parts of the Trust to see if we can do similar things and continually learn about that.
I bet it's a real eye-opener to teams, actually, to discuss other aspects of
it is, and I think people really are on board with this type of inquiry, and I think it's recognising that a public health approach is everybody's business. So you don't need to have public health in your job title to be able to do work that involves preventing poor health, addressing those building blocks for health and supporting our patients with access to healthcare and thinking about health inequalities. It's everybody's job, and if we all do it, we will be able to make a bigger difference to population health.
Yeah. And we've heard about the term, it's been on our trust websites and intranet, about the term MEC. What does that stand for and what does it mean? And
Okay, yeah. I'm pleased you've asked me that because I'm passionate about MEC.
Yeah, I know you are, yeah.
MEC is making every contact count.
Yeah.
And it's an approach that across our whole North East region actually is a big programme, and it's about recognising all of the different contacts we frontline workers have with the people, patients, population, and being able to make those conversations, those routine conversations, everyday conversations, a little bit more purposeful.
Yeah.
So rather than talk about maybe the holiday or, it's thinking about kind of how can we make that contact count so that we understand what matters to that person in terms of their health and well-being and those building blocks.
Yeah.
So having a purposeful conversation. So what matters to you might be, I'm worrying about my bills, I'm worrying about paying the heating, I'm actually worried I've had an invitation to have a vaccination, but I'm not quite sure why I've had that invitation, or I'm a bit worried about the side effects. So it's getting our staff to be confident in having conversations where they can make a difference to those building blocks.
Yeah.
It might be about somebody we notice has got a tobacco dependency.
Yeah.
If we don't have a conversation about somebody with a tobacco dependency, we're actually denying them the opportunity to make a difference to their health that will be as important as any medicine that we give them. So having that conversation about, did you know that if you get help to support you with your tobacco dependency, you're more likely to be able to stop smoking?
Yeah.
Did you know that people who get help do often quit, and that will make a big difference to how you feel, your breathing. It will save you money. So it's just being able to be confident. You don't have to be an expert in each of the areas, but having that conversation. And we've got a fantastic Gateway app web resource. So the Gateway app, when we're having our conversations, there are different tiles. So if what matters to the person is being more socially connected, we can go onto the socially connected tile on the website, and we can look at the services and the groups that are available where they live to be able to signpost them to things that will support their health and well-being when they go home from hospital or after they've had their appointment. And it helps build those that capacity and those assets for the person to be able to be healthy and well for longer.
So it's really important, isn't it? And I found that it's changed my clinical practice doing my MEC training, and I can then teach my juniors and the staff on the ward. And people are really invigorated by thinking about people's lives outside of hospital, and what matters to me is at the heart of our clinical strategy, because it's about personalised care. So
Absolutely.
It's really important that we can take that forward, can't we?
Yeah.
So we've talked a little bit about our patients and our people, but some of our people are our staff. So does the public health team have any commitments to our staff health and well-being?
We absolutely do. So our staff, if we think about our staff, a lot of our staff live in the communities that we serve.
Yeah.
So actually, if we support our staff to be healthy and happy and support their health and well-being, we actually are improving the health of the population.
Yeah.
But also our staff need to be healthy and well to be able to look after our patients, so we need to care for them so that they can care for patients. So our public health work within that staff health and wellbeing agenda is really important. So we've mentioned health inequalities. Our staff also experience health inequalities. They all have different lives beyond work. So public health helps to look at the information that we have about staff through that health inequality lens. So we can see that, for example, if staff are off with sickness absence, that might be different for different groups of staff, or the reasons why people might be sick or absent from work might be different for different groups of staff. So we look at the data, we look at, we do an annual survey where we ask staff questions about what matters to them, what is their health and wellbeing looking like. And that helps us to be able to plan the interventions and the programmes that we offer to staff to keep them healthy and well. Public Health has a staff health and wellbeing lead, Stephen Chater, who is a key role within the partnership of colleagues that work on this agenda in the Trust. And we have things like health and wellbeing champions. So teams will have a health and wellbeing champion that work very closely at a team level to promote the offer that's available to staff. We do a range of things, right from, what keeps you healthy. So being physically active, we're doing a lot of work around Step Into Spring. So engaging people in group activities where they can walk and count the steps and challenges like that. We've got programmes like the active offices. So some of our staff have jobs where they're sitting more, and sitting isn't really good for us all day. So an active office encourages us to think about how can we put movement into the office day. So it could be like walking and getting a drink, or having a little walk at lunchtime, or walking meetings. Standing desks rather than sitting desks. So Public Health's very active around that. We've done a lot of work around the cost of living. So it's been really challenging and continues to be really challenging for people in terms of their home finances. So thinking about welfare benefits. We've had a pilot in the Trust with Legal Care where we've offered staff access to financial and legal advice. We've got a partnership with Northumbria Community Bank where staff can save, so that, when it comes to Christmas, etc., you've got a little bit of money behind you to pay for things that you need to at Christmas. And we have a dashboard, so we can look at our staff's health and wellbeing needs and where we need to target and focus. And this year we're prioritising women's health. So 80% of our workforce are women.
That's huge, isn't it?
And there's lots of inequalities in the health experiences of women. So there's a national women's health strategy. So we're looking at how we can implement that strategy for our workforce, and that includes things like looking at how we support women during the menopause, how we support women to access things like sanitary provision, keeping safe. So lots of work around physical activity from a gendered point of view. So that strategy is really one of our key focuses. Another one is around mental health and wellbeing for our workforce. So we know one of the main reasons for people being off work is mental health and anxiety. So what can we do as an employer to promote mental well-being, as well as make sure when people are needing some more specialist support, they access things like staff psychology and occupational health services. So lots going on in that arena. It's a very busy space, and we're very proactive in wanting to make a difference. It's really key.
So our Trust is also a sort of a big name in the North East. It's a big employer. What's our sort of corporate responsibility around public health and the population we sort of serve?
So I don't know whether you're familiar, Charlotte, with the term an anchor institute. But that's about, as a big employer, we make a real difference at place. So, if you think about the numbers of people that work for us,
that's huge, isn't it?
That kind of impacts upon the local economy. It brings work and education opportunities to the local population. We purchase things as a big organisation, so the things that we buy, again, will make a difference. So our choices around procurement and purchasing make a difference. And so we have a range of things going on as an anchor institute. So it's looking at kind of things like access to employment for the local community. So how do we widen those opportunities and reach out to communities that maybe are further away from the job market? So we do a lot of in-reach into local schools. We work with the voluntary and community sector. to capacity build to sort of support them as health asset makers. We've got some really good innovation around things like apprenticeships. So we've increased the number of apprenticeship opportunities in the organisation, and we've actually reached into communities where maybe there isn't a history of them working in the health sector. And that's beneficial to that community, but it's also really beneficial to us because we get the talent
coming
of
in.
Those people coming into our workplace and their experiences and how they can kind of open our eyes to things that we can do differently and better. So it's a real opportunity, and it's thinking about health as an asset. How come, and our organisation as an asset and a health creator at place. Really important and very exciting work going on in that area.
So it sounds like there is absolutely loads going on in the public health department. There's, and it's really at the heart of our clinical strategy. So you've used the terms what matters to me for both our staff and our patients. We've talked about how the trust has got responsibility, and we've talked about how teams can think about bespoking their work to think about other determinants of health, not just the problem that the patients are there for, the wider aspects of the patient's life, which goes right back to personalised care, doesn't it? And actually really sort of getting down and having those clinical conversations. So great work. So
thank you.
And I know there's loads of information on both the intranet and the Trust Internet from projects and stuff going on.
So we have a public health portal, and there's lots of information on the portal about things that we all can do in this area. So I would welcome people to have a look at the portal. And we have externally, we have the health inequalities pages that people can look at as well to see what the Trust is doing around addressing those health inequalities. And we very much welcome people getting in touch to kind of talk about any areas that they feel they would like support with, or where they would like to make a difference, and how we can support them to make the difference that they definitely can make.
Good. Well, hopefully you won't be inundated, but I'm sure you will. So thank you for coming to talk to us today and just explaining how public health is part of our clinical strategy.
Thanks, it's a pleasure. Thank you.